again, my student. Today we continue with part 2 in chapter 4, which covers the same topic, conquest of infectious diseases. In the end of the last lecture, we ask, what do we do when we don't have vaccine? The answer, when vaccines don't exist for a disease, or if a disease is too rare to justify vaccinating everyone, we rely on epidemiologic surveillance. This is our early warning system. Public health practitioners watch for disease threats so they can step in and break the chain of infection. The classic response is a quarantine, isolating the patient to prevent them from infecting others. Quarantine is still used today. For example, a patient diagnosed with tuberculosis might be ordered to stay home for 2 to 4 weeks after treatment starts until the disease is no longer infectious. Accompanying quarantine is the process of contact tracing. Contact tracing is the public health response of locating people who have hit contact with the infected individual. For tuberculosis, we locate exposed people and give them prophylactic doses of antibiotics. This is also routinely used for sexually transmitted disease like syphilis. Once case is identified, the public health workers ask the patient to identify sexual contacts, and the worker then discreetly notifies those contacts that they have been exposed without identifying the source. They can then be readily cured by penicillin. These classic methods are incredibly powerful, as shown in our next example. The example is, in November 2002, a high infectious new disease called severe acute respiratory syndrome, called SARS, emerged in southern China. Because China did not first report the disease, it spread rapidly, most notably infecting more than a dozen guests at a single hotel in Hong Kong, who then carried it to several other countries. We had no drug effective against this virus, and lab tests couldn't diagnose it quickly. Yet, by July 2003, WHO declared that SARS had been contained. How? Strictly by old fashioned measures, quickly isolating suspected patients and quarantining anyone who had come in contact with them. Since 2004, no known cases of SARS have occurred anywhere in the world. Now, let's look at the disease that requires constant management, rabies. Rabies is a fatal viral disease of the nervous system. It kills an estimated 59,000 people around the world each year. usually contracted through a dog bite. However, in the United States, human exposure is relatively rare because the human vaccine is expensive and inconvenient, requiring several injections over a month. Routine immunization of everyone is not recommended. Instead, we used a different strategy to break the chain. Let's see what that is. Because the rabies virus infect only mammals and wild animals, serve as the reservoir, our first line of defense is creating a barrier. We achieve this through the mandatory immunization of dogs and often cats against rabies. If a healthy appearing domestic dog or cat bites a human, we simply observe it for 10 days. Rabies virus affect the brain before being secreted in saliva. So animal capable of transmitting the virus will already show symptoms and die within a few days. That give us sufficient time to give the bitten person the life-saving series of vaccinations. But wildlife is a different story. If a wild animal bites a human, there's no way to test it alive. It must be killed and it brain tested for signs of the rabies virus. During 2017, the CDC recorded 4,454 rabid animals. Nearly all were wildlife, primarily bats 32% and raccoons 29%. Controlling rabies is significant and costly also. Testing an animal costs about 100 US dollar and series of vaccinations of a person can cost as much as 1500 US dollar. In one incident in 1994, a single rabid kitten in a pet store led to 665 people receiving post exposure treatment, costing over 1 million US dollar for the vaccines alone. Now, let's discuss diseases we actually have a chance of wiping off the face of the earth entirely. Smallpox. Smallpox was a particularly feared disease that emerged in Asia around the time of Christ and spread in major epidemics, claiming millions of lives. But it is also the disease that originated the concept of vaccination. The observation that survivors were immune inspired the idea of inoculating people with matters of from mild cases. Practice George Washington even ordered for his army. In 1796, the British physician Edward Jenner proved that inoculations with cowpox matter provided immunity against smallpox, making the procedure much less risky. This set the stage for a massive global effort. By 1958, routine immunization had eliminated smallpox in industrialized countries, but it was still killing 2 million people a year in underdeveloped nations. The WHO, with support from the United States and the Soviet Union, launched a global eradication program between 1967 and 1977. Because smallpox lesions were so conspicuous, medical teams could track outbreaks just by showing picture, locate patients, quarantine them, and vaccinate everyone in the vicinity, sometimes by force. It was an incredible success. The last case was found in Somalia in October 1977, but that success leads a modern controversy. Today, the smallpox virus officially remains in only two places: stored in laboratories at the CDC and in Russian lab in Siberia. They were scheduled to be destroyed in 1999, but fears about a bioweapon and the 2001 bioterrorism attacks put those plans on hold. Scientists are still debating whether to destroy the virus or keep it to study improved vaccines. However, one major concern is that the molecular consequence of the virus is publicly known. This means someone could synthesize it in the laboratory anyway, perhaps making the entire equation of destroying the remaining stocks debatable. Let's look at our next target for eradication: polio. Polio eradication goal. Like smallpox, the polio virus infects only human beings, meaning polio similarly has the potential to be totally eradicated. In 1988, WHO set a goal of eradicating polio by the year 2000. While that goal was not met, annual polio cases were reduced by 99% worldwide by 1999, effectively eliminating it from the Western Hemisphere and Europe. By 2018, only two countries had endemic polio: Afghanistan and Pakistan, with only 33 cases identified. So, why haven't we crossed the finish line? Polio is proving far more difficult to eradicate than smallpox for a few reasons. First, many invisible cases occur where children spread the virus by the fecal oral route without showing any symptoms, making it impossible to easily target small outbreaks. In addition, the polio vaccine is imperfect and requires several administration to become effective. Furthermore, the political upheaval severely interferes with the work. In 2003, for example, a rumor in Nigeria that the vaccine caused AIDS or infertility led states to halt vaccination, causing a massive regional surge. We also face backsliding challenges with a disease we once thought we had beaten, measles. Before vaccine became available in 1963, look at this figure, almost all children contracted measles, leading to 400 to 500 deaths and 4,000 cases of chronic disability annually in the United States. As illustrated in this figure, once the vaccine was introduced, cases dropped. In, in 1979 or 78, 1978, the United States actually set a goal to eradicate measles by 1982. But the ambition proved overly optimistic. We discovered that the immunity conferred by vaccination in infancy wears off, necessitating a booster vaccination for older children and adolescents. Let's look at recent outbreaks. Measles was declared eliminating from the United States in 2000, meaning all cases could be traced to individuals who contracted it outside the country. But cases started rising again. In 2011, 222 cases were reported, and 86% of the American residents affected were unvaccinated or had unknown status. The majority of those who were unvaccinated missed their shots because of philosophical or religious belief. In 2014, cases surged to 644, driven by an outbreak among unvaccinated Amish children in Ohio, and major exposure even originated at a Disney theme park in California. The situation escalated further in 2018. One of the largest recent measles outbreaks began in October 2018 with an Orthodox Jewish community in New York. Patient zero was a 14 years old boy who had recently acquired the disease in Israel and then attended a holiday service at 7,000 person capacity synagogue. Public health teams partnering with a local rabbi had meticulously mapped in the interior of the synagogue to retrace contacts and determine who was susceptible host. Ultimately, the initial exposure led to 654 cases in New York City and 414 cases in the other parts of the New York state. Now, what happens when an eradication efforts fails completely? We look to malaria. Malaria has no non human reservoir and it is transmitted by a certain species of mosquito. In the 1950s and 1960s, it was the target of an international eradication campaign that relied heavily on the pesticides DDT. But the campaign failed. Funding ran out before the objective was achieved, and the disease returned with a vengeance. Mosquitoes became resistant to DDT. The pathogen developed resistant to the drug chloroquine, and population lost their natural immunity due to the lack of exposure. Today, malaria remains incredibly widespread, killing an estimated 1 million people annually, proving that a failed campaign can cause devastating harm. A major barrier to disease control today is the fear of vaccines. Unfortunately, public public suspicion has spread linking the measles vaccine to autism and the pertussis vaccine to sudden infant death syndrome or SIDS. The autism fear was heavily foaled in 1998 when a British surgeon, Andrew, published a fraudulent paper in the Journal of the Lancet. An exhaustive investigation proved he was guilty of misconduct. He, mis- he misrepresented facts and cooked up a scheme to profit from lawsuits against vaccine manufacturers. The Lancet retracted the paper and the scientist's medical license was withdrawn, but the damage to public trust was done. How did the scientific community respond? The vaccine safety reviews. To address these widespread concerns, the Institute of Medicine conducted major review of the evidence. In 2003, they concluded that evidence favor rejection of relationships between vaccines and SIDS. In 2004, they similarly rejected a causal relationship between the MMR vaccine and autism. They cited a massive study in Denmark analyzing record a half of million children, which conclusively found that unvaccinated children developed autism at the exact same rates as the children who had been vaccinated. Despite this evidence, fear persists and endangers our communities, as we see on the next slide. This fear leads parents to use religious or personal belief exemption to avoid state law requiring school immunization. They count on herd immunity, the phenomenon where the majority is vaccinated, thereby protecting those who refuse the vaccine. However, herd immunity is actually meant to protect infants too young to be vaccinated and people with weakened immune system. If the percentage of immunity in population fails too low, often in a wealthy communities refusing the risk of immunization, outbreaks are highly likely putting vulnerable people at massive risk. Because the severity of recent outbreaks, states like California and New York have legally revoked non medical exemptions. The consequences of this fear go beyond localized outbreaks. Parents' tendency to blame vaccines for any health problem lead to frequent lawsuits against pharmaceuticals campaigns. Combined with the low prices charged for vaccines, this liability has caused many campaigns to end their vaccine production altogether, threatening our supply. And if we stop vaccinating, disease surge back, as seen in Russia in 1980s when the public health system was in chaos, resulting in 200,000 cases of diphtheria. Furthermore, we often blame social media, but anti vaccination sentiment spread incredibly effectively through tight knit traditional social network via words of mouth. So, where do we stand today? Let's look at the current status. We have much to celebrate. CDC data from 2016 shows age adjusted death rate for many infectious diseases are at all time lows. Influenza and pneumonia kill about half as many Americans as they did in 2000, and the death rate from HIV has fallen by more than 80% since it peaked. Rates of new hepatitis and tuberculosis cases are also near all time lows. Conversely, measles has beaten back eradication efforts even in rich countries, and rates of new syphilis and chlamydia cases have more than doubled over the last 20 years. Great gains have been made, but infectious disease are far from being completely conquered. In conclusion, public health has had great success by interpreting the chain of infections, killing pathogens, eliminating reservoirs, preventing transmission, and increasing host resistance through immunization. We successfully conquered smallpox, but our ongoing battles against polio and measles show that eradication is complex and subject to backsliding. Moving forward, we must combat the reluctance to vaccinate, which weakens our herd immunity and allows controllable diseases to return. Ultimate success against infectious disease required adequate resources, constant vigilance, and strong political will. Thank you for your time and see you in the next lecture. Goodbye.